at things? Okay, yeah, it's very good. I'm going to move around a lot, so if that's going to make anybody dizzy, now's your time to put your hand up and say so. So let me give you a little bit of background about me. I've been working in healthy ageing for about 20 years. I'll show you some of my research as we go through, and that'll give you a better idea of the fact that I probably know a little bit about what I'm going to talk to you guys about. Falls is not my speciality by any means. All my stuff is very much in the reduction in disability through exercise with older adults. But very much I see falls as an important part of that, in that if we did exercise and we were proactive about reversing our own disability, falls would become less of a problem for us. Some of the things I'm going to say to you might be very confrontational. I won't be holding back on my opinion of what's currently going on in the sector, the aged care sector, and of how I feel about who should be taking ownership in relation to some of these falls that occur as well. So I don't ever mean to offend, but hopefully some of the stuff I say will be eye-opening for you and give you something to take away. So you guys have probably seen this before. This is quite old. This comes from the World Health Organisation and Alexander Kalashay's life course model. The first third of our lives, we can just sit back and relax. We're going to get fitter, faster and stronger. We don't need to do too much about it. And even if we make poor lifestyle choices during that period of our lives, often we can push out the consequences till we're into the later part of the second third of our lives. But for a lot of us, we reach that second third of our lives and we enter the final third of our lives and we crash towards disability. Disability increases by about 10% per decade. So if we don't have any levels of disability by the time we get to our 70s, we can fall from there to community dwelling healthy and happy to residential aged care within that 10-year bracket. What we also know is if we adhere to healthy lifestyle choices, and this is just not exercise, but also diet, reductions in stress, getting enough sleep, a variety of things like that, we can push out our health life expectancy. And a lot of us, when we adhere to these lifestyle choices, may never need to go into a dependent care situation. At the centre of all this is this term sarcopenia or frailty. They're the same side of the one coin we talk about. Sarcopenia used to be defined as this loss of muscle mass, but we've been a bit more clinical about it now, and we look at it as a loss of muscle mass, a loss of muscle strength, and a loss of physical performance. But it sits very much as the central cog to a variety of things which drive us towards higher levels of disability, higher risks of falls, higher rates of chronic disease. In the initial cases, quite fit and healthy, we might have the interaction of some level of disease. We might get diagnosed with high blood pressure or high cholesterol. And that's the first step towards that, if we don't address it then and there, escalating to become something else. And as it drives our levels of physical interaction, it also drives our losses of muscle mass, which then influences how well we can get to the letterbox or up the flight of stairs or around the shopping centre, how much strength and power we have to get out of the chair, let alone get off the toilet, how our walking speed starts to decline, and then all through these other cycles, which very much put us closer and closer to physical disability. So we also know that our risk of disability is very much driven by this loss of muscle mass. And by no means does the loss of muscle mass parallel the losses in strength and function. What actually happens is muscle mass sort of ticks away from about the 30-year onwards mark and can slowly but surely decline over the rest of our lifespan. And then once we get into our 50s, we can have significant losses in our strength and significant losses in our functional performance, which then determine our ability to interact with our day-to-day lives. Some of the things we always take for granted is all these other things. Fit, healthy, good muscle very much determines my aerobic capacity. Often we think of aerobic capacity as just heart and lungs. But if I don't have competent muscle, I can't draw oxygen out of my blood at the muscle level and then return smaller muscle oxygen-filled parcels to my heart. When I have inefficient muscles, I need to drive more and more blood to those muscles to get them to have the same level of oxygen. My metabolic rate, when I have less muscle, I also have a smaller metabolic rate because all my muscles are always turning over energy. Less blood volume, which means I have less nutrient carrying capacity. Less body fat, more body fat rather, because I have a decrease in my metabolic rate. Bone mineral density, I find it phenomenal, people don't put it together. Bones are the levers through which my muscles work. So when I use my muscles regularly, and I use them against reasonable resistances, my bones respond by getting bigger. In the other instance, where I sit for longer, where I'm more sedentary or undertake single contractions, then my bones respond by getting smaller. And we'll talk about the dangers of osteoporosis, especially in the concept of falls, very, very soon. And of course, my quality of life is subjective measure, but definitely, if I'm young, I'm fit and I'm healthy, then my quality of life is bound to be higher than if I'm stuck in a chair watching TV waiting for somebody to come around to my home. The other things, frailty and sarcopenia, we've talked about, and very much we're here to talk about the influence of my balance confidence, and with my loss of my balance confidence, the increase in my risk of falls, declines in my functional ability, and increases in my dependent care needs. But there is one answer, there's no doubt about it, and we'll talk a lot about this today, and that is undertaking exercise or being more regularly physically active. And the evidence we have, and I won't harp on so much about this sort of evidence today, but we know that no matter how old you are, how disabled you are, or what is your level of disease status, that exercise has benefits for you. We show this over and over again. In Southern Cross Care, we've got 16 gymnasiums in 16 residential aged care facilities. And we've seen people turn around, walk faster, have better balance, not use their wheelie walkers, and then that influences their levels of chronic disease, their levels of depression, and then that influences their ability to interact with other people. Okay, so falls. Very simple definition, an unexpected event in which an individual comes to rest on the ground floor or lower level. Very much we use it as any of those events where somebody ends up on the ground when they didn't expect it. And that's the same as the World Health Organisation. Okay, yeah, hold on, I'll just get all these up. One of the things I find the most amazing about falls is a lot of these figures have never changed in the last 40 years. The rate of 30 to 40% for those people over 65 years of age who fall each year, one fall each year, hasn't changed in about the last 40 years. We've got greater than 2,000 research studies that have looked directly at interventions that have positively shown that we can change falls rates, but yet these rates still continue to be the same. It's fine, isn't it? Isn't it great? So 50% of those in the institutionalised situation will fall at least once each year, and if you have something like dementia, then your risk increases by another 25%. And if you fall over once, your risk increases by about another 25% of falling over again, until it becomes like a double-edged sword where you fall over more and more regularly. About half of those who fall do so repeatedly. 20% of falls need medical attention, 5% result in fracture. But of that 5%, the outcomes can be unbelievably devastating for the individual. For a lady, for an older woman who falls over and fractures her hip, her risk of going to institutional care from the community setting is about 50%. And then her risk of dying within the next 6 months is again about 50%. So think about that. Your 80-year-old grandmother falls over in the home after she's been independent and all that sort of stuff, and given those figures, she could be dead within the next 6 months. It is the leading cause, and it continues to be the leading cause of accident-related injury and hospital admission. And just recently, we've also had it identified as the leading cause of avoidable death in the residential aged care setting. And 93% of avoidable deaths were caused by falls in the residential aged care setting, in a study which had some 14,000 people. So as I said, these figures have been very, very similar for many, many years. So this study is done quite a while ago and came out in Lancet by Knass And he showed in a Finnish population that incidence of hospital-treated falls, incidence injuries had increased between 1970 and 2002, with the increasing risk, ageing of the population, the increase in the number of occurrences, and then they projected for women and female that that would continue to grow with the ageing of the population. And in Australia, we're no different. We've spent some $470 million per year directly related to emergency department entry for people with falls. And if we look at just Queensland figures alone, because I'm from Queensland, that about 23% increase over the past decade in relation to falls-related hospital admissions into the emergency department for older adults. So, falls are very multifactorial, obviously. We have things that we'll talk about now in relation to exercise, in relation to muscle weakness, gait speed, balance disorders, functional impairments, and then other things that I presented to my lifestyles and allied health teams the other day that they didn't really think was their role. Visual impairment, cognitive impairment, side effects of drugs or hazards in the environment. But I presented to them any of these things that they notice actually is part of their role to identify it and feed it up the chain. And I think this is one of the things that we're seeing that keeps these falls rates very, very high, is we only take ownership of our direct contact with the client. So if we're in exercise, the exercise that we do, as long as we do it with the way we've been taught to do it, the client enjoys it and they come out of our service, we're doing our jobs. The allied health professionals, if they're doing their treatments and their therapies, then once they leave our service, then what happens outside of that is not our job. But very much so, everything which happens in relation to a fall, whether it's fatigue, whether it's lack of muscle weakness, whether it's a visual impairment, whether it's a drug side effect, if we notice any of these things, we should surely be taking ownership of that and reporting it back up the chain. I'm going to very much talk about the top things here in relation to how we can positively influence falls. But I think one of the things, as I want to reiterate, we just don't want to take ownership of the fall. Nobody wants to take ownership of the fall, so these rates continue to be incredibly high. But I think if we're looking at an organisational or an allied health intervention, we need to be case studying, trying to take ownership of all of these risk factors for the individual so that we can help that individual reduce them, prevent them, and then they can change their falls pathways. So just to give you some background evidence, there's a lot of data around that shows that muscle weakness is definitely related to falls risk. This study done by Moreland looked at 13 papers that they put into a systematic review publication process. And they showed that lower body weakness had a increased 1.76 times increased risk of falls if you had lower body weakness, and that was increased to 3.06 times risk of a fall for a recurrent fall if you had lower body weakness. And this was also translated across upper body. So if you had upper body weakness, it also linked directly to an increased risk of falls. One of the big markers that we know, and again often take for granted, is gait speed. So gait speed as a measure in itself is very much emerging as one of the most powerful clinical markers we have of increased risk of disability and other negative outcomes for our older clients. So mobility disability, mortality, dementia, institutionalisation and hospitalisation have all been linked as to having low gait speed. I'm sorry you can't see this real well from here, but we know that if you walk at 1.3 metres per second, you're relatively safe. So as you start to come lower and lower on that table down towards this 0.8 metres per second, your increased risk of all these other negative health outcomes starts to increase significantly. And once you get to about 0.8, your disability and your morbidity, your mortality risk starts to increase quite significantly, and also so does your falls risk. In fact, a couple of years ago, this famous paper came out by Stanaway that suggested that if you walk at 0.82 metres per second, your risk of mortality was only 2 years away, and that you needed to walk at 1.36 metres per second to avoid all sorts of mortality risks. So it's become quite famous because he actually called the paper, How Fast Does the Grim Reaper Walk? And they collected data, again, from a massive population of people to demonstrate its high risk. And just revisiting the current topic that we're on, again back to the Alban van Can paper, they showed when they looked at some specific papers, some very large prospective studies with people up to 7,500 people, that walking speed was a direct predictor of falls risk. So the slower we walk, the greater our risk. And amazingly, in the residential aged care setting, we allow people to come in and we allow them just to progressively get slower and slower in their walking speed. There's data around that suggests that in the first 6 months of being in the residential aged care setting, your walking speed can almost halve from what it was at entry into that environment. In the community aged care setting, things aren't greatly different. The more in-home services we offer to people, the more we allow them to sit in those chairs and be sedentary, the more we drive a slowing of their walking speed. And it's not just the speed at which we walk, it's the way we interact with the ground, the way our feet strike the ground, how big our base of support is, which also play very important roles in our increased risk of all those negative things we talked about and in the increase in the risk of falls. This is one of the things I'm trying to get my clinicians to do at Southern Cross Care, to be aware of the way people walk. And you guys have all seen people, they walk forward, driving their centre of gravity forward to create momentum, and they're driven forward to fall. And often if they don't fall this way, they can't successfully overcompensate when they get a toe catch, they'll fall backwards, and that puts them at a great risk of busting a hip. If they fall forward, greater risk of busting a wrist. So all these things, stride length, support base, step time, they become very complicated, and I don't know what half of them mean, but they're the things you think about in your head when you think about that hunched over, wide base of support. Interaction with the ground is flat-footed, so there's no toe to heel drive like we should all be walking. Returning to what I was saying about bone mineral density before, this is one of the other great risks for the older adult in relation to fall. Having a fracture as an outcome reduces their capacity to return home, to then continue to have an independent life. And once we remove a percentage of that independent life, people don't refill it with other physical activities, they refill it with time on the couch, time in front of the TV, time in sedentary behaviour. And these are all negative drivers of falls risks. So just to show you, probably know the figures, the fracture risk for older men and older women actually moves at parallel, but because of menopause for women and the loss of estrogen, that loss of bone mineral density actually kicks up a couple of notches post-menopause and puts them at that fracture threshold at an earlier point in time. Osteoporosis, you probably understand as well. It's a decrease in the microarchitecture of the bone, both internally and externally, where when that bone is put under excessive pressure, it is more likely to fracture and break than it is to come through the process. The sites of fractures are also very common. You should understand these. The hip, the wrist, and spinal fractures are the three greatest risk locations for older adults. So deteriorated can some people's bone mineral density, if they sneeze, they can fracture ribs and they can fracture their spine. It takes a little bit more to fracture a hip, but as we discussed earlier, if you fall over and bust a hip, then your risk of never going home and other negative things can be quite high. So I want to talk to you about progressive resistance training and weight-bearing exercise. I am very much a one-eyed pie on this scenario. This is the work I've been doing since I finished my PhD in 2008, and even goes back into a long history of research that I did to get to my PhD position. There is no doubt about it. It is the most powerful stimulus towards an older adult being well into later life than any other modality of exercise or activity that we can have available. But unfortunately, it continues to be the most underutilised, And when people do say that they're doing it, commonly they're not doing it well. And we'll talk about some of those things as we go through from here on in. So resistance training can improve muscle mass and muscle strength. I'll show you some data around that. Muscle power, so defining muscle power from muscle strength for you guys. Muscle strength is my ability to move a force. Muscle power is related to my ability to move that force rapidly. But we often take for granted that a lot of things that we do in our day-to-day life relies upon our muscle power. Our type 2 muscle fibres, which shorten and lengthen a variety of velocities. So when I stand up from a chair, for example, I need to coordinate muscles between my ankles and my midriff. Some are lengthening, some are shortening, and they're doing it at a variety of velocities. My muscle power determines how successfully I can do that. And when I can't do it successfully, worst case scenario, I fall over because I can't coordinate my centre of gravity over my centre of balance. Best case scenario, I might fall back into the chair where I first started. And then everything in between. And this is why we see people fall in bathrooms so regularly, getting off the toilet, they stand up badly, they tip over forward, they extend a wrist out. Again, worst case scenario, they might break that wrist. Bone mineral density, we talked about this before. The greater the stimulus, the more regular the stimulus, the more I challenge my muscles, the more it actually returns strain through my bones, and my bones respond by getting bigger. And we are never too old for that. I had ladies who entered my PhD studies in 2004 who 6 years later went from osteoporosis to normal bone mineral density. 6 years of continuous training and targeted training. And I'll talk about the specific target areas soon. It improves our sleep profile. One thing we take for granted, but we have better sleeping profiles. We also have decreased risk of other cognitive disorders. It improved my capacity in activities of daily living. My symptoms of disease decreased, both my physical diseases and my mental diseases. And I won't talk about dementia today, but we know that people who have greater total body strength have up to a 41% reduced risk of developing an Alzheimer's disease. And it significantly reduces my falls risk, and if you do it right, there's big residual impacts that can protect your activities of daily living, protect your muscle mass, protect your bone mineral density for up to 6 months post-training intervention. But this is not the sort of resistance training I'm talking about. I think this lady's actually got 1 kilo dumbbells. In some of my gyms, I'm getting ready to throw out the 0.5 kilo dumbbells. They're not even heavier than a bottle of sauce that you pick up at the supermarket. Why would I be asking somebody to do repetitive resistance training with them in my gymnasium? The sort of resistance training I'm talking about is this sort of stuff. Machine-based, higher intensities, specifically targeted muscle groups. And even though a lot of these machines look like torture chamber exercises for the older adult, they are by far the safest and most successful way for people to gain muscle strength that can transfer to their activities of daily living. It's very hard to fall out of a machine, but it's very easy to fall off the edge of a bench or fall over when you're transitioning from a chair to a standing exercise that you might be doing as a group-based exercise. So to give you a brief history of some of the evidence, this is stuff from my PhD. So my PhD looked at 2 types of training. Both had a high intensity type protocol. Both the training groups, and you can see the lines that parallel upwards, trained for 24 weeks, and the line which is relatively flat is related to people who did no exercise at all. These guys did 6 exercises: chest press, back row, bicep curls, leg press, leg curls, and leg extensions. And independent of whether they used a muscle power type training regime where they were asked to move as fast as they possibly could, or a muscle strength training regime where they were asked to work against a high resistance for 3 sets, they had big changes in their muscle strength. 40% was the average increase after 6 months in muscle strength in healthy community dwelling older adults. That translated to large improvements in muscle power. They also had 15% increases in a range of activities of daily living measures: standing, climbing stairs, walking backwards, doing balance exercises. They also had a 2% increase in muscle mass, and they had a 2% decrease in body fat. And the groups that did resistance training had no change in their bone mineral density, but the control group had a slight decline over the 6-month period. We took these principles and we applied it to the respite setting. So respite day therapy, you guys understand the setting I'm talking about? And what we did there, we used body weight dumbbell resistance to do a 20-week exercise program where people in the respite setting did 1 hour per week. That's all they did, 1 hour per week for 20 weeks. They had a large warm-up where they used large muscle groups, arm rotations, facial movement, shoulder shrugging, marching their feet. Then they had 5 targeted resistance body weight exercises, and then they did a stretching cool down. After that 20 weeks, they'd had increases in their left and right grip strength. They'd had decreases in their habitual and their fast 6-metre walk. So the time it took them to walk over 6 metres. They'd had very large increases in their chair standing capacity. So big significant increases. Chair standing is what we call a biomechanical independence defining task. So the data suggests that if you can stand up from a chair by yourself, there's a good chance you can look after yourself. If you can't do it without using the arms of the chair, your walker, your table in front of you, there's a good chance you need some level of assistance. We also had big decreases in their timed up and go, the stand up, walk out 3 metres, around a marker and return back to seated. And we had big improvements in a progressive balance test where they had to do stand side by side, semi-tandem, full tandem, and then a stand on one leg. So more recently, the work we've been doing has been coupling those resistance training principles with some of these principles about bone and targeting improvements in bone mineral density, and most recently we've started to incorporate all the evidence about falls reductions, and I'll show you some the data that gives recommendations about falls prevention in a moment. So we know that to increase bone mineral density, we need to have upper, lower and trunk exercises. Programs need to be done regularly and they can adhere to general resistance training recommendations. A single set is the minimum, but commonly we suggest that people do up to 3 sets. Exercises need to be done at a moderate to high intensity. They need to be specifically targeted towards the sites which have the greatest danger. So you can't be doing leg exercises and expect your wrists to get stronger. You need to be doing leg exercises for your hips, and that leg exercise needs to be for quads, hamstrings, glutes, and your abductors and adductors. And likewise, you need to be doing upper body exercises to try to improve your wrist, and then likewise for your spine. Movements need to be dynamic and varied. Isometric, not so great, but definitely dynamic, full range of motion activities. The bone load needs to exceed that which it normally would. And that's just working against the high resistance until fatigue for these sort of 8 to 10 repetitions. However, there is some exercises we need to be mindful of. One of the dangers in some of this stuff is if we over-fatigue muscles, they can actually pull at deconditioned bone, and that deconditioned bone, especially around core spinal fracture, can break away and could lead to a spinal fracture scenario. So incorporating that with some of the most current evidence we have of what a falls prevention program should entail. And this all comes from Kathy Sherrington's paper, where she's done a systematic review of some 50 falls prevention interventions that have been run nationally. And she says that programs need to be moderate to high, have a moderate to high balance challenge. So they cannot just be resistance training. They need to have balance specific exercises, and I'll show you what those balance specific exercises are very soon. They need to have a sufficient dose to have an effect. And what she suggests is that it needs to be 50 hours of contact. And that just debunks a lot of the programs that we run, which are an 8-week, once a week falls prevention program. The organisation I worked for in Queensland a number of years ago, we did a big organisational review of all our falls prevention programs, 1 hour per week for people with CHSP or home care packages, and we found out they did not work at all because the dose was not sufficient. So 50 hours these programs need to run for, and we interpret that to be twice a week for an hour each time for 24 to 25 weeks. The programs need to be ongoing. They can't be an 8-week intervention and then you go on and you're expected to do it yourself. They can be general community, and for those at greater risk, they have impact across all age groups, in other words. They can be done in the home or they can be done in the clinic. They cannot be walking alone. There's actually a lot of negative evidence in relation to the impact of walking alone as a increaser of falls risk for people. They should be inclusive of some level of strength-based training, and we need to be aware of other risk factors. So we've been embracing all this evidence, and we've been running some very large and beneficial studies up in Queensland rather. The first one I'll describe to you is a study which is just coming to its end now. It's called Muscling Up Against Disability, and it was originally funded by the Department of Social Services, but more recently by the Department of Health. We have people come into a gymnasium-based scenario where we have all these specialised HER equipment. They do 24 weeks of resistance training twice per week, and then they go into a follow-up period, and that's what we're coming to at the end of, up in Queensland at the moment. We've had some 260 people enter this study, and we're having very positive outcomes for everybody, and I'll show you some of those outcomes very soon. The resistance training equipment is for leg press, chest press, leg curls and extensions, abdominal and back, adduction and abduction, and they use a thing called the optional ROM, which is a back machine. So you can see one of the ladies on her walker. All these people are CHSP clients. The balance exercises that we've incorporated are a static standing, a dynamic activity where they need to do a tightrope walk, one foot directly in front of the other, and we do box stepping with these people as well, where they need to step inside a box and we transition them to increased repetitions around that box. Now, for a lot of these people entering on a wheelie walker, you guys are thinking exactly how dangerous, doing a single leg stand or a dynamic tightrope walking exercise. But one of the things I'll talk to you about very soon is how we've progressed them. We've progressed them so they've got full contact with the wall, or they've got full contact with the surface, which gives them increased confidence. And then slowly but surely we reduce the amount of contact that they have with that surface and increase the amount of work that they actually do. So much so that now, for the tightrope walking, we've got people who came on wheelie walkers originally, and they walk across foam pads, doing their foot in front of the other, and then they walk backwards for their 10 steps as well. And they do that without touching the wall. So some of the basic data that we've got coming out of this study as well is we've had big increases in upper body core and lower body strength. And we've had big increases in isometric leg strength as well, which gives a direct translation to chair standing ability, climbing ability for stairs and walking ability and so on and so forth. We're getting into some of the other data at this point in time. We're having very positive outcomes for all the measures within the short physical performance battery, which has a chair stand task, a walking task and a balancing task. We're having positive outcomes across each 3 of those measures, and then of the summary score as well. So much so that some of the people who entered the study with a marker for frailty no longer have those markers for frailty. And on top of that, we've got all these positive testimonials. People are not using their walkers as much, people have reduced levels of pain, people have reduced numbers of medications. A PhD student of mine has applied almost exactly the same program to the residential aged care setting. So Jenny Hewitt, she's coming as well to the end of her study. She's had 220 participants who were randomised to either controls or to exercise. They had, as you'd expect for the aged care setting, 86 years of age, 26 months in care. She did exactly the same program that I just described to you for the Muscling Up Against Disability. And what Jenny has shown is beyond phenomenal. Her exercise group had a 55% reduction in falls in comparison to any of the control group, the usual care group. This is about 40% more than any study which has ever appeared as a falls prevention intervention. She had incredibly high adherence as well. Out of the people who came and joined her study, she lost about 2 people over the entire study. One died and one just couldn't continue with the program. But everybody else came. They did as many of those sessions in that 24 weeks as they could possibly manage given their setting, their situation, their diseases, their changes in situation. So, and one of the things that stops people doing this sort of training in the residential aged care setting is the fear and risks that they might associate to it. But she had 0 adverse events. The only adverse event she had was when people complained about muscle soreness. And if any of you guys have ever been to the gym, you actually know that muscle soreness in relation to gym training is a positive thing, not a negative thing. So specific to balance and what programs should incorporate, they need to have 3 types of exercise. One for static balance, one for dynamic balance, and one for agility. If you think about the types of times that people fall, how often do we see somebody who's not got strong legs? They might look up and they might tip backwards. There's nothing there that makes them fall except they have a low capacity to maintain that static balance position. The other one, probably the most common reason for fall, is dynamic balance, where somebody's moving forward, they're dragging their centre of gravity forward, and they catch their toe on a carpet or they catch their toe on a curb and over they tumble. And the final one is agility, our ability to change direction while we actually have momentum going forward. And as I said before, one of the things we really need to adhere to, and I think as clinicians a lot of people really lack in their programs, is progression. I see all too often with clinicians, people come into the gyms, people come into their clinics, they have great programs, they make a few progressions early and then they're just allowed to normalise and keep ticking along at that pace from there on in. But we really need to feed these gains. We need to feed progression until that person actually plateaus. I explained to you before in relation to how we've done that sort of progression with my Muscling Up Against Disability program, and I'm working very hard at Southern Cross Care where we've got clinicians doing parallel bar walkthroughs and obstacle courses, but they allow that client to walk through that bar, grabbing hold at every position. So progression needs to be part of the training program. We need to look at reducing their reliance on what they're doing, but of course we need to be smart about it. We don't progress people from one week to the next. Some people it might take them 2 or 3 weeks to achieve the first level, then it might be 2 or 3 weeks to achieve the next level, then it might be 2 or 3 weeks to achieve the next level, but that progression needs to be there. And there's a variety of ways to do it as well, which I don't have time to go into now, but smart clinicians positioning themselves well and using their room and their environment well can significantly reduce the risk of any adverse events when they're doing this sort of training with people. So just a few examples of the sort of things that should be incorporated. Single leg stand, incredibly great activity. What I do with a lot of my older clients is I ask them when they brush their teeth at night, in front of the vanity, put one hand on the vanity, lift one foot off the ground and brush their teeth. And the next night, other leg, and so on and so forth, just to try to work on that single leg stand. Dynamic activities like obstacle courses or that tandem forwards walking, backwards walking can have great dynamic balance outcomes for the individual. But remember what I was saying before, trying to minimise the contact that the person needs as they cross between those parallel bars. And the one I probably use most regularly for agility is the figure of 8 walking, where we start with a massive figure of 8, the size of this room, and as people progress, we get that figure of 8 smaller and smaller and smaller and smaller and smaller. Now there's also other programs that we shouldn't ignore that have great outcomes for older adults. The Otago exercise program has received a lot of positive attention, has had big changes in people who were previous fallers, and it is a reinforcement that something is better than nothing for people who are not doing any level of exercise. Tai Chi has gained a great reputation for lower body strength, for lower body balance, and also in relation to falls reduction. And if you're going to advertise in any of your clinics Tai Chi, it definitely sounds better to the older client than a balance prevention a falls prevention program. Environmental modifications is something we also need to be aware of. If you go to the person's home, whether they have any toe catch hazards, whether they have any big trip hazards around the house, whether they're trying to overdo things outside of their capacity, which puts them in a dangerous position where they can fall over. And then one of the other things for the residential aged care setting, which has had some very positive outcomes, is hip protectors. And what that's proven to do is it gives people greater confidence because they're not as fearful of the fall and then the repercussions of that fall in relation to a negative outcome like a broken hip. So I just wanted to reiterate to you, before I finish, some of the other values of resistance training. So we do know that muscle mass is more predictive of early mortality than body fat. So when people have bigger muscles, they've actually got a greater life expectancy, and what we're seeing more and more is BMI is not the greatest predictor of early mortality. So we need to increase our muscle mass. We need to have good, strong, well-used muscles. Sarcopenia I talked about a little bit a while ago. In relation to risk of institutionalisation, frailty and sarcopenia, as I said, are the same side of the one coin. And they're very big drivers of people falling into the disability sector and then into the residential aged care setting. Oh, no, sorry, I've got those slides. I'm looking at the wrong slide page. Okay, I'll go back and I'll talk about dementia. I mentioned you guys dementia before. So 41% reduction in developing an Alzheimer's disease when you have higher total body strength. Sarcopenia, as I just mentioned, and a reduced risk of post-surgical complications also comes with greater muscle strength, greater functional performance, and greater muscle mass. And the study we're looking at here comes from Carly. It's quite old now, but they talk about the value of prehabilitation. Somebody who utilises their 32-day elective surgery lead-in period, who gets physically fit, who then has lower risk of falling deep below the functional threshold and therefore has a greater chance of climbing back to independence after they leave the hospital setting. One of the other things I want you to think about as well is the complication of return to standing once somebody has a fall. I don't know if anybody watched The Four Corners last night, but the gentleman who fell over and lay there for 5 days. And that's not something which is obviously reserved to Aveo. That happens day in and day out in Australia. And his story is actually a good one because somebody found him. A lot of people might die on the floor because they can't return to stand. So while we're thinking about these balance exercises that I've given you in relation to falls prevention, also thinking about trying to add exercises into people's programs that allow them to return to standing. And it's complex, it needs a whole lot of individualised movements, but it's very possible to give people back that capacity and give them back that confidence that if something did happen, like they fell over and they were by themselves, they could actually get themselves off the floor and at least to a phone so that they could get help. So very close to finishing. So there's no doubt about it, resistance training is an incredibly powerful but underutilised stimulus for our older adults as a preventative for disability and as a rehabilitator from disability. Programs do need to be of a higher intensity, they do need to be challenging. Definitely sitting around in a group environment and banging a balloon across the room is not going to reduce disability amongst older adults. It can prolong and increase independence. And that's what we should want. We all want to live in our homes longer, very much so. It can significantly reduce falls and falls-associated injuries, especially when we look to current evidence and incorporate that sort of evidence into our programs. It should have it has a positive change in the direction of disease progressions, and I haven't talked about that greatly, but definitely we see people reducing their risk of disease, reducing their medications, reducing their symptoms. And it has powerful client and provider personal and financial benefits. And just, I don't know if you've seen these guys, Charles Euster does a TED talk that is very worth listening to. 95 years of age, just smashed the 200 metre record for his age group. And Jean Stewart, who started doing CrossFit training when she was 80 years of age because she didn't like conventional older adult type training programs. So, that's all I've got for you. Thank you.
No.